Medurstand. Understanding medicine.
I am Professor Aziz-ur-Rehman, and I hope that you have attended my earlier 3 lectures on anemia. One was on approach to anemia. Then we had one lecture on interpretation of CBC, where I emphasized that this very simple test gives you a lot of information if you examine it critically. And then we also had a differential diagnosis of common anemias. I hope you are now ready for this quiz. Like always, this is a revision in the form of a quiz. I hope you will find it interesting. Now let's start. Which of the following is not a typical feature of chronic iron deficiency anemia? So the choices are going to appear. Which one is not a typical feature? That is what you're going to find. These are the choices: hypochromia, macrocytosis, microcytosis, reduced MCV. MCV is mean corpuscular volume, and reduced ferritin. Which one you think is not the feature of chronic iron deficiency anemia? Macrocytosis. Because hypochromia, microcytosis, hypochromic microcytic picture is a typical of chronic iron deficiency anemia, and reduced MCV is the same as microcytosis. And then we also the cause behind this is iron deficiency, that is reflected as reduced ferritin. So macrocytosis is not the feature of chronic iron deficiency anemia unless there is an additional pathology. Then of course that is due to additional pathology. It is not due to iron deficiency. In iron deficiency you get microcytosis, not macrocytosis. Let's take the next question now. Which of the following is not an indicator of anemia due to chronic vitamin B12 deficiency? Oval jolly bodies, hypersegmented polymorphs, ovalocytosis, reticulocytosis, and increased MCV, mean corpuscular volume. Which one is not an indicator of anemia due to chronic vitamin B12 deficiency? That means everything is correct except one. Which one is that? Reticulocytosis is not a feature of vitamin B12 deficiency, because any deficiency will actually slow down bone marrow activity. Reticulocytosis is a sign of increased bone marrow activity, and this will occur in vitamin B12 deficiency once vitamin B12 is replaced. In fact, that is one of the confirmatory signs of vitamin B12 deficiency, that after you start eating and you give vitamin B12 in the form of injection just to make sure that it gets into the system, and if there is prompt reticulocytosis on day 10 or 15, that would confirm that it was actually vitamin B12 deficiency. Now, in vitamin B12 deficiency, although bone marrow is hyperplastic, but there is maturation arrest. So cells are not maturing, so they will not appear, the reticulocyte will not appear in the peripheral blood, and that is why reticulocytosis is not a feature of vitamin B12 deficiency. Reticulocytosis is mostly associated with the hemolytic anemias. All right, let's move on to the next one. In the absence of any obvious external or internal blood loss, which of the following will indicate the possibility of haemolysis? Hypochromic microcytic picture, reticulocytosis, reversed polys and lymphose ratio, pancytopenia, koilonychia. Which one of the five choices given here indicates the possibility of hemolysis. It could occur in external or internal blood loss also. So that I have excluded. There is no blood loss, internal or external, or no obvious bleeding, but there is a possibility of hemolysis. Which one would indicate the possibility of hemolysis? Reticulocytosis again. Because we just discussed reticulocytosis reflects increased bone marrow activity. Now, assuming there is hemolysis and assuming that bone marrow is healthy, the bone marrow will respond physiologically by producing more and more RBCs. For that, it would require to be hyperplastic. So, bone marrow is expanded, is producing more and more cells. So, at any time, you have more percentage of young cells which are reticulocytes. So, presence of reticulocytosis in somebody who presents with anemia with no obvious cause will definitely raise the possibility of hemolysis. Of course, there are other possibilities, but in the absence of other possibility which can be ruled out clinically, reticulocytosis should raise the possibility of hemolysis and further tests should be done. Let's move to the next question. Causes of macrocytic anemia includes all of the following except vitamin B12 deficiency, folic acid deficiency, chronic renal failure, hypothyroidism, chronic alcoholism. Which of the five is not accepted or known or recognized cause of macrocytic anemia? I think this should be easy. Anemia of chronic renal failure is actually is never macrocytic because the cause of anemia of chronic renal failure is very complex, but the main factor is absence of erythropoietin or reduced level of erythropoietin. You all know erythropoietin is a hormone which comes from the kidneys and it stimulates the bone marrow. So once kidneys are damaged to a significant extent, erythropoietin level will be reduced and bone marrow will become very, very sluggish. So once bone marrow becomes sluggish, it will produce fewer number of RBCs, but those cells which are produced, they should be normochromic and normocytic. In some cases, they may be hypochromic also, but I don't really think they could ever be macrocytic. So in chronic renal failure, you never get macrocytic picture. That is why this is the correct answer. Whereas vitamin B12 deficiency, folic acid deficiency, hypothyroidism, chronic alcoholism, they're all causes of macrocytic anemia. These two would cause macrocytic and megaloblastic, and these would cause macrocytic non-megaloblastic. This point was covered in my lecture. So the megaloblastic picture is seen in the bone marrow. Moving on to the next one. Direct Coombs test, which is now called anti-globulin test, will be positive in which of the following conditions, right? Now, the conditions are spherocytosis, which is a hereditary disorder, pernicious anemia, where the problem is in the stomach, the parietal cells are damaged and they're not producing intrinsic factor and vitamin B12 is not being absorbed. Immunohemolytic anemia, you know, this is an autoimmune disorder, G6PD deficiency, and paroxysmal nocturnal hemoglobinuria, which is an acquired condition where there is hemolysis due to antibodies which fix complement. So in which of these five conditions direct Coombs test, the anti-globulin test, will be positive? And I told you in my lecture that direct Coombs test will test the presence of antibodies which are immunologically bound to red cell antigens. So in which you think these antibodies will be positive? I guess this is also easy. Immunohemolytic anemia, because this determines the presence of antibody, and immunohemolytic anemia, as the name says, is because of the antibodies formed against some of the RBC antigen. Okay, so far you're doing very well. 2 weeks after starting injectable vitamin B12 in patient with pernicious anemia, which of the following will indicate a good response? Now, you know, first of all, we have just given injectable vitamin B12. We haven't given iron. We haven't given anything else. And we already know that this patient has pernicious anemia. And in pernicious anemia, there is problem with the vitamin B12 absorption. And that is why we give injectable vitamin B12. Now, we already have the diagnosis. But which of the following will further confirm that we are on the right track and the diagnosis is correct? Increase in hemoglobin, and you are just testing how much? 2 weeks. Okay, after administration of vitamin B12, only 2 weeks after, you are testing these things, and increase in hemoglobin, reduction in macrocytosis, reduction in number of hypersegmented polymorphs, increase in the reticulocyte count, and absence of Howell-Jolly bodies. Which one in retrospect will confirm that we are actually dealing with a case of pernicious anemia and we are treating the patients correctly? If you are treating correctly, then of course you expect improvement in hemoglobin. You also expect a reduction in macrocytosis, reduction in number of hypersegmented polymorphs, but all these are going to take time. Howell-Jolly body disappearance will also take time. So since this is 2 weeks only, so I think answer should be clear. It is the increase in reticulocyte count. In these patients, bone marrow is hyperplastic, but there is maturation arrest. So in the process of maturation, at a certain level, there is arrest. Behind that, there is a lot of cells. It's just like, imagine traffic block. Once the blockade is removed, then there will be prompt movement of the vehicles. So that's like, it's exactly like that. So once we give vitamin B12, that block is removed, bone marrow is already hyperplastic, there will be prompt hemopoiesis, and in 2 weeks time you will see the reticulocyte count has increased from maybe 1 to 2% to 10-15%. So this will actually confirm the diagnosis. If you do not have the facility of vitamin B12 assays, and if you do not have the facility of anti-parietal cells to confirm pernicious anemia, or the possibility of Schilling test to confirm pernicious anemia, you could use this technique, measure reticulocyte count, give vitamin B12, and after 2 weeks, if there is prompt reticulocytosis, that would confirm that patient actually had vitamin B12 deficiency. So simple but definite way of making a diagnosis. Which of the following is not a recognized feature of thalassaemia? Right? You know, in medicine, nothing is absolutely right or wrong. So we have to see which one is generally considered to be correct answer. So which of the following is not a recognized feature of thalassaemia? Increased ferritin level, reduced mean corpuscular volume, reduced mean corpuscular hemoglobin, splenomegaly, and pancytopenia. Which of these is least likely to be present in cases of thalassaemia? Mostly thalassaemia minor, or maybe major also. So which one you think does not fit in the diagnosis of thalassaemia? I would say pancytopenia. because thalassaemia is a disorder which selectively affects hemoglobin only. In fact, not only hemoglobin, just a beta chain of a hemoglobin, or in some cases alpha chain. And it does not have any effect on rest of the RBCs, and it should not have any effect on other bone marrow cells and other the platelets. So there is no reason in thalassaemia for platelet to be reduced or WBC to be reduced. So there should be no pancytopenia. This one does not fit in the diagnosis of thalassaemia. Moving on to the next question. Which of the following is not a clinical feature of pernicious anemia? Now we are talking about a clinical feature and about pernicious anemia. Cardiac failure, sensory deficit, muscular weakness, koilonychia, and pancytopenia. Which one is not a feature of pernicious anemia? Pernicious anemia is anemia due to vitamin B12 deficiency, especially due to autoimmune antibodies against parietal cells. If you have attended my lecture, this should have been very, very easy. It is easy. So koilonychia. Koilonychia, I mentioned in my lecture, is not actually a sign of anemia. It is a sign of chronic iron deficiency. So since we're talking about pernicious anemia where there is no iron deficiency, koilonychia should not be present. All these are features of macrocytic anemia. That is why we call it pernicious anemia. Pernicious is something which could be fatal. So cardiac failure can occur, sensory deficit and muscular weakness can occur because of subacute combined degeneration of spinal cord, and pancytopenia because vitamin B12 is required for DNA synthesis, and DNA is required for the formation of all 3 cell series in the bone marrow. So typically there would be deficiency of RBC, there may be deficiency of white cells and also platelet. Not to the extent we see in aplastic anemia, but you would definitely see some reduction in TLC and platelets in cases of pernicious anemia. Now moving on to the next one, I think we are getting close to the end. Which is not true about aplastic anemia. And you all know aplastic is a condition where bone marrow, the healthy hematopoietic bone marrow, is replaced by fibrous tissue or fat tissue. There is no functional bone marrow. Is not true. Reversed polys and lymphos ratio. Normally polys are more than lymphos. So if that ratio is reversed percentage wise, pancytopenia, normochromic normocytic picture, reticulocytosis and purpura. Which one is not the feature of aplastic anemia? Reverse polys lympho is in fact one of the cardinal signs. Pancytopenia should always be there because it is aplastic, so no cell line will be unaffected. Normochromic normocytic picture, I told you that in this condition fewer RBCs are made, but whatever RBCs are made, they look normal. Reticulocytosis is actually a sign of increased activity, and we are talking about aplastic anemia. Purpura is a clinical sign due to thrombocytopenia, which can occur in these patients because they have pancytopenia. So the answer is reticulocytosis. Reticulocytosis is not present in patient with aplastic anemia. So far so good. In which of the following situations erythropoietin therapy is mostly indicated? Now, mostly indicated means there are other conditions also where erythropoietin may be indicated, but I just want the one where it is a standard of care. Every patient with that condition should receive erythropoietin. Iron deficiency anemia, aplastic anemia, anemia of chronic kidney disease, hemolytic anemia, and sideroblastic anemia. In which of these following conditions you think erythropoietin will really help? In fact, during this quiz, we discussed this issue, this point. It is the anemia of chronic kidney disease, because in anemia of chronic kidney disease, there is actual deficiency of erythropoietin. Erythropoietin can be given actually in patients with anemia of chronic disease, also in patients who have received bone marrow transplant, and also maybe in aplastic anemia. We, as a desperate attempt, maybe we can try, but in iron deficiency anemia, there is no need, because once we replace iron, there would be haemolysis. And so out of these, anemia of chronic disease is the correct answer. Okay, thank you very much. This was a brief quiz. I hope you liked it. I am Professor Aziz-ur-Rehman from Medurstand, and I really look forward to see you in my further videos. And soon I'm going to release, I think maybe this time I'm going to release lectures on calcium and vitamin D related disorders. So I expect that you will join me there. Till then, thank you very much and bye-bye. Professor Aziz-ur-Rehman from Medurstand.